Hi, I'm Joyce Harper, Professor of Reproductive Science at the Institute for Women's Health at University College London. Welcome to Season 3 of my podcast, Why Didn't Anyone Tell Me This? This season, we'll be diving into topics that explore how to achieve good health and happiness. I'll be speaking with leading experts who will provide evidence-based advice and debunk some of the many myths around our health. Additionally, I'll be having conversations with individuals who bring unique perspectives through their lived experiences. In Season 3, we'll cover a diverse range of topics, including reproductive anatomy, inspiring female icons, chronic health conditions, factors that influence our well-being, and global women's health issues. I really hope you enjoy Season 3 of Why Didn't Anyone Tell Me This? Welcome to the second episode in my mini-series about understanding chronic health conditions. And today we're speaking to Professor Neil Gittoes about understanding osteoporosis. Neil is consultant endocrinologist at the Queen Elizabeth Hospital in Birmingham and honorary professor of endocrinology at the University of Birmingham. He graduated from the University of Birmingham with honours in medicine and anatomical studies and has a PhD in molecular endocrinology. Neil is recognised nationally and internationally for his work in metabolic bone diseases, including osteoporosis, vitamin D deficiency, and disorders of calcium homeostasis. He has co-authored recent international guidance on management of parathyroid diseases and UK guidance on osteoporosis. Neil was awarded the Augustonian Lectureship at the Royal College of Physicians in London and has had many key roles, including being the current chair of the Royal Osteoporosis Society. Welcome, Neil. It's so great to have you on my podcast today.
Good morning. No, you're very welcome.
Now, I always start by asking my guests what led them to their career. So what led you to a career as an endocrinologist and then to become a specialist in bone health?
Yeah, sure. Endocrinology is a bit of a strange specialty, some think. You have to almost define it. It's, study of hormones and glands, but it's far more complex and sophisticated than that. And I think it's the complexity and so many unanswered questions that led me to it. It's a thinking person's specialty, and I enjoy that. I suppose problem solving, etc. One of the things that it doesn't do an awful lot of is using your hands, and I miss that a little bit. But I think within endocrinology, and particularly within the bone area, it allows you to look at major public health issues like we're talking about today, osteoporosis. It affects so many people. But within my area as well, there are really ultra rare diseases, highly challenging. And in fact, the developments in my field are huge at the moment, probably more in this than any area of endocrinology. Just a combination of kind of complexity, thinking, being able to make a difference, both at scale of public health and on a very individual basis with some of the rare diseases. And I still find it nicely challenging. And I think that's important if you want a kind of a long-term, interesting career.
Absolutely, totally get it. Now, let's start with the basics. What exactly is osteoporosis and how does it differ from general age-related bone loss?
Yeah, sure. So osteoporosis is a description of bone weakening, essentially. So perhaps trying to be a bit graphic, and bringing it back to chocolate, which is not a bad place to start. If we think of kind of a crunchy bar, and if you break it in half, you get that kind of honeycomb center. And as you look at that, that's what kind of healthy bone looks like inside. It's this connected interplay of kind of small struts that make things very light and very strong. And that's what kind of good quality bone looks like. In osteoporosis, and it happens in fairness, linking to your second point, as we get older, men and women, we lose some of those connections. The connections become thinner and some of them break. So even if you think of that in terms of, like, another analogy is scaffolding. If you look at scaffolding on a building, it's all highly interconnected. You start taking out one or two or three of these pieces, and actually you wouldn't feel terribly confident climbing up that scaffolding. And it's the same with bones. As you lose those interconnections, and often we talk about density of bones, in other words, the amount of material there is within that network, as we lose the quantity, the bones become weaker, thinner, and more susceptible to breaking. So osteoporosis is a clinical entity. In other words, how does it affect you and me? It's all about fractures. So not just what your bones look like, but what is the likelihood of breaking a bone. And unfortunately, there is a difference between women and men, and over the age of 50, every other, i.e., 1 in 2 or 50% of women, will have what's called a low trauma or a fragility fracture in the rest of their life. So this is hugely common, hugely common. When I say fragility fracture, that means having a tumble, just tripping over something, putting your arm out, breaking your wrist, your arm, or heaven forbid, hip. That's one thing that everybody wishes to avoid. And the other fracture, I suppose, that is not very, hasn't got great awareness in the public is vertebral or spinal fractures. They are hugely common and often go missed. So age-related bone loss, it happens in all of us to an extent, but it varies. And women around the menopause have an accelerated rate of bone loss over perhaps 2 to 5 years. So the rate of change is in some can be quite dramatic, whereas men don't have that equivalent period in their life. So their loss is more linear and slow.
That is scary numbers, 1 in 2 women. So
Mm.
let's dive deeper a little bit into some of that. So it's often called the silent disease. As you say, if you break something, then you know, and you get the alarm bells. So are there any other signs besides actually breaking something? Are there any typical
Mm.
signs or symptoms that we could realize that maybe something's wrong?
Yeah, it's a critical question, isn't it? And there's a lot of misunderstanding and misconceptions around that. And unfortunately, the quick answer is no, there are no other features of osteoporosis unless a bone is broken. Often people will say to me, I've got awful aches and pains in my shoulders and my arms or whatever. It's probably it's my osteoporosis, isn't it? And long story short, the answer is no, it doesn't work that way. And that's why, as you say, the terminology of the silent epidemic, in other words, happening in the background, we don't have a lot of awareness of it unless something goes wrong. And that, I suppose, links to, well, there are features to look out for in terms of making someone more susceptible to it, and that's the way we should be going here. So this is a preventable problem, so it's just a case of identifying it. And in one of the things I do, I'm chair of the board of the Royal Osteoporosis Society. We put in a huge amount of energy into people using an online risk checker. So if you're thinking, well, hang on, there's some family history. My mother or my grandmother had a hip fracture when she was 70. I wonder what my risk is. Yes, there are things like bone density scans we can do, but as a first line, in other words, to tell the system a little bit about what your risk factors are, there's an online risk checker which is being taken up by many hundreds of thousands of particularly women that give you within a couple of minutes what your risk is of fracture. And of course, if you're into that domain of higher risk, it's worth talking to a GP, probably getting a bone density scan and taking it from there, because this is a preventable condition. You can prevent fractures. We've got very powerful medicines that do that.
That's really important. So I will put the link to that test, that
Yeah, thank
online
you.
survey that we can do. I will put the link in the show notes for sure. That's really, I didn't know about that, so it's really important. I'm going to do that as soon
Mm.
as we finish. So you mentioned the family and family members having had a problem. So is there a genetic risk of getting
Mm.
osteoporosis?
Yeah, it's a big statistic. So about 70 to 80% of our bone density, basically our bone strength, is conferred by our genes. So there's a huge amount that we carry with us from our parents that sit in the background, the genetic makeup of our bone density. So your start point is really important. There are things we can do in terms of maintaining that bone density, but if your genetic susceptibility is towards having perhaps lower bone density than some, it's really important to get on top of that, particularly if there's a clear family history of osteoporosis, or of fractures, vertebral fractures, hip fractures in particular. But there are many other risk factors that we can consider. There's quite a long list of risk factors that um, on that risk checker I was talking about, we touch upon those as we go forward. And I suppose that, a really simple one is if you've had a fracture before, think about, hang on, is that just me being unfortunate, or could there be some background osteoporosis? And that links as well to, again, something that the charity is pushing very hard on. Some people may have come across this terminology of fracture liaison services. So if you're looking to prevent a condition, you go to a person who's already shown features of it, in other words, had a fracture. So this service that's present in just under half of all hospitals in England, you get picked up by a fracture liaison service. They look at your risk factors. Many people will have bone density scans, and then there is an intervention after your first fracture to prevent the second fracture. And in an ideal world, we would prevent the first fracture, and there's a different route to getting to that, and perhaps screening is a way to go with that. But there are systems in place, and we are lobbying hard, and in fact have assurance from the government that fracture liaison services will be implemented throughout the country by 2030. So this is providing an NHS on the front foot service with a big emphasis around prevention to try to prevent that big fracture, that hip fracture that I'm sure we all know people who've had a hip fracture. 20 to 25% of people will die within a year of a hip fracture, and people lose independence. And I think that's the saddest part of this when I see people who've been leading a carefree life and just a single event can change them from being outside contributing to life to metaphorically sitting looking through the bay window at life, because you lose a lot of mobility if you have a bad outcome after a hip fracture. So this is an important area, and I keep coming back to it. There's plenty we can do to prevent it.
I'm glad you mentioned the hip fracture, but I've heard some more worrying statistics, especially for older women, that it was very high that um, related to your chance of being dead within a year or two. But you said 20 to 30%. Is it higher if you're older and if you're a woman?
So it's higher. It goes up with age, and it goes up in line with the term comorbidities. In other words, if you're carrying a lot of other medical conditions with you, and in fact, it's higher in men. There's less hip fractures in men, but it's all to do with kind of that package of health or ill health. And often, as you imply, a hip fracture can be, I don't want to be overstating, but can be, in inverted commas, a terminal event. In other words, something that just tips people over the edge, and it's difficult to recover from a hip fracture. So that is if we make the analogy, the kind of the big heart attack, the kind of the wrist fracture may be a little bit of angina, whereas a hip fracture is the big heart attack that we would do everything we can to try to avoid.
And I've had a number of friends who have literally just been walking and they've had a very minor trip and then they've broken a bone. So that is that a warning sign?
It is. So I think the start point there is let's have the conversation, let's do the tests. And it might be, the other end of the spectrum is you've just been really unfortunate. You might have really quite good bones, and in which case, the message would be we shouldn't forget about the relevance of falls as well, because I think we're in a world where people are rushing around doing all sorts of things and probably possibly not paying enough attention to what's in front of them. So we can't kind of diminish the importance of falls, but yes, something like that. And I use the terminology fragility or low trauma fracture, and that's defined as having a fracture as a result of a fall from standing height or less. Classical one is out walking the dog. Dog pulls you, you kind of get pulled over or you trip. And the wrist fracture is a very, very common fracture. But then, the other classical osteoporosis fractures is the shoulder or the neck of humerus, the vertebrae, the spinal fractures, and the hip fracture are particularly commonly associated with osteoporosis. And there are lifestyle things we can do. So it's not all about drug therapy. Weight-bearing exercise is fantastic for bones. The bones like the impact and the vibrations that go through them as a result of walking, or if you wish and you're capable of more kind of gym based or jogging based, or but walking is great for the bones. So I wouldn't underestimate the importance of that. Um, Vitamin D is absolutely central to bone health, and the summer we've just had, in fact, if we've it's been difficult to perhaps not get enough vitamin D if you've been out and about. But through the winter months between October and April, all of us, if we stay in the UK, our vitamin D levels will fall into at least the insufficient or deficient level. So supplementation is good. Over the counter is good. And from a lifestyle perspective, particularly, enough protein in the diet as well as enough calcium, resistance training. So it's about strength as well as the impact side of it. And of course, not smoking. Smoking's bad for all sorts of things, including your bones, and just moderation with alcohol as well. So these are things that we as individuals can do for ourselves to promote our bone health.
I've been talking a lot about the importance of lifestyle and as you said, exercise and alcohol, etc. Um, there has been some controversy about vitamin D recently that I've heard. Some people saying that it's no point supplementing. Some people saying there are. So there's always the problem with social media. So your view is we should be supplementing?
Yeah, vitamin D is, you can have a major conference, and there are major conferences on vitamin D. It's been proposed as kind of a cure-all in some arenas, and in fact, there's a fantastic body of scientific information behind vitamin D, getting well away from bone and calcium side of things into, preventing heart disease, cancers, all sorts of things. And it's a fascinating area, which I suppose it's not the purpose of why we're here today. So when it comes to bones, it's really important to, the doctors, and to convey the understanding of the physiology of how bones and calcium, vitamin D, and various hormones work. So, in essence, as we go through winter, as our vitamin D levels fall, because you can't get enough in your diet, you have to supplement if you wish to keep your vitamin D level good. There's a hormone called parathyroid hormone, PTH, which rises physiologically, in other words, naturally. What that does is it starts to steal calcium from your skeleton. Fact, that's the way the system works. So if we allow that system to go on for too long, we can actually create some really quite severe bone problems. Not in everybody by any stretch of the imagination, but the backdrop is by taking vitamin D, we avoid that hormone level going up to work against our bones. So what we wouldn't be proposing is to say, oh, take vitamin D and that's the treatment for your osteoporosis. That would be naive and outdated thinking. But to have vitamin D on side, so it's not working against your lifestyle factors, it's not working against any drugs that you may be taking. So it's that belt and braces type of approach. And people often think, well, I need to take the calcium, but if you have a good level of vitamin D, your body's very efficient at absorbing all the calcium it needs. So the action is around vitamin D rather than the calcium. And in fact, in people up to there's no age cutoff, but let me say into mid 70s or towards 80, most of our gut will be able to absorb good levels of calcium as long as we have levels of vitamin D that are satisfactory. And actually, taking calcium is not the nicest thing to do. It's often very chalky. So, by having good levels of vitamin D, a good balanced diet that's rich in calcium, that hits the spot very nicely from a lifestyle perspective, and it promotes bone health.
Excellent. I take vitamin D, so absolutely. Yeah, you mentioned food. There's a lot of discussion. Sorry, a lot of discussion about ultra processed food. So, can ultra
Mm.
processed food damage our bones and increase our risk of things like osteoporosis?
Yeah, so I think jury's out specifically on that. It is an area that is attracting lots of attention, and I think there is a story to tell there in terms of links to, gut microbiome, ability to absorb nutrients and minerals, etc. And the speed at which those data are being accumulated would very much promote that an ultra processed diet is not going to be giving those micronutrients, in fact the macronutrients as well, that we require for what I would say kind of systemic good health. And I just mean kind of bodily, the entirety of the body, including the skeleton, because I think there is still this perception of the skeleton that it's that thing that we saw perhaps in school hanging in the corner, either a real one, not these days probably, but a plastic one, and it just sits there. It's not very interesting. It's just a thing that the rest of the interesting body hangs off. But the skeleton is so alive, vibrant, and dynamic. All those metabolic and cellular processes going on in both of us as we speak now. We're removing small packets of bone that are perhaps not as good as what's going to be laid down, over the next few weeks. So it's hugely alive and responsive to the nutrients that we're talking about. It doesn't just sit there. It's not a piece of Lego. It is actually replacing itself as we speak. And that links back to one of your earlier points around age-related bone loss. So in women, as they go through the menopause of the change, the deficiency or the drop in levels of estrogen mean that more bone is taken away from the skeleton that is deposited. So you have a net loss of bone, which accounts for the generation of osteoporosis in that type of setting.
Yeah, we'll come back. Sorry, we'll come back more to the menopause in a moment. I just wanted to dive a little bit more. You mentioned screening, and you have mentioned bone density scans. So, are there some screening that we can do? I did test out a urine test a while ago for a company. So, where are
Mm.
we with screening? And if you then are diagnosed, well, how would you be diagnosed?
Mm. Yeah, it's a great and highly topical question. Screening, actually. Um, and again, the Royal Osteoporosis Society, one of our probably 10-year time frame objectives is move towards a national screening program for osteoporosis. It is a hugely common, prevalent condition, and so your mind starts lighting up as to this is ripe for screening. So a number of years ago, in Birmingham, where I work, we were one of 7 centres that recruited to an MRC study looking at screening older women between the age of 70 to 85, something called the SCOOP study, where we looked at the feasibility and also the cost effectiveness of providing a screening program for at-risk people, in other words, older ladies. And long story short, we could demonstrate a reduction in hip fracture risk by 30% by screening a population and treating with various products, various drugs that we have available to us. And also, really helpfully from a system and policy perspective, it was cost effective to screen. So that story is emerging as we speak. But as you can imagine, to introduce a national screening policy, there's a huge amount of work there. There's a national screening program and team that is working in the background, and we have conversations with them. So in due course, we may well, for an at-risk group, look at how can we use often simple questionnaires, um, sometimes bone density scans as part of a package to look at fracture risk. I think the here and now, where we don't have that, comes all the way back to the risk checker. So doing your urine tests or whatever is that's okay. There is no evidence around that. So I think my view is where you have a complex system, try to introduce simplicity to make it manageable. So here, because we don't have something, there is no harm, there is no very little minimal cost in performing a clinical risk checker. Tell me about some of the features of your life. Is it a kind of a green area? Is it an amber area? Or is it a slightly red area? And take it from there. So for me, the best we have at the moment is this risk checker. And it is based on good, hard scientific data, because perhaps not for here and now, but there is a slightly more sophisticated tool called FRAX as well that is available to every GP, in fact, every clinician, that gives you an accurate score of your risk of major fractures and hip fractures. So the tools are, you can probably tell the way I'm talking, we've got various tools out there, but they're not quite as joined up as they should be. And because this is a silent disease, there's a lot of emphasis on the person or the patient to kind of knock on the door to say, can we look at this, please? Because it doesn't come actively out for you and reach into the screen and say, it's you, and we really need to do this. Some active screening programs do that, breast cancer, bowel cancer, and all the rest of it. But at the moment, we're having to do quite a lot for ourselves at the moment.
That's really important. I really want every, especially women, but everyone listening to this to go and do that risk checker and to be proactive. I think you've given some really, really good advice there, which won't take very long. And I'm all for preventative medicine. I think it's so important. Can I just ask if someone goes for a bone density scan? Can you just briefly say I've had a few and they're really non-invasive and they're fine. I just don't want people to be scared of them. So can you just tell us roughly what happens?
Yeah, sure. No, it's a nice, straightforward, no risk procedure. So a bone density scan or a DEXA scan, a DXA is usually its abbreviation. You'd walk up to a friendly imaging department, X-ray department, probably fill in a form, which comes back to that kind of risk checker type of element, and then you just lie on a bed. It's a bed that's in an open room, and above you, about less than a meter above you, will be an arm, a plastic arm, that slowly the bed moves, and your various parts of your body, predominantly the spine and the hip, get scanned. It's nowhere near your face. You can talk, you can look at the room, as long as you keep still for the scanning part of it. It takes about 15 to 20 minutes to do, and you're done essentially. But there's no tunnels, there's no banging and clattering, and music needed to be playing. And those of us who've had MRIs, they're not the most pleasant things. So really simple, and importantly these days as well, kind of radiation, because we forget about radiation, but this is less than a chest X-ray. So it's something that we often do repeat, particularly in people on therapies, perhaps every 2, 3, 5 years, but highly accessible. In fact, in fairness to the government, they've recently provided funding for some additional scanners across the country. There's still often a wait time in some areas, but in terms of usability, really simple, not in any way scary.
Yeah, I totally agree. So please don't worry. It's definitely nothing like an MRI, which I've always found a little bit stressful. Now, you've mentioned a few bits about treatments. So what can we do?
So, as always, I think from someone who has no osteoporosis and is reassured by their bone density, we would give the lifestyle advice that we've already spoken about. Those with perhaps the most severe, difficult osteoporosis, we would give lifestyle advice. So that's, if you like, the backdrop. In other words, that self-empowerment. What can I do for myself? Then above and beyond that, we have lots and lots of drugs. When I started in this area, we had a limited number of drugs, and we were often kind of caught out by, oh, there's a scenario and actually the drug doesn't work very well in that setting, or there's this going on and we can't. Whereas now we have drugs that we can offer daily, weekly, monthly, 6 monthly, annually. We can give drugs by mouth as tablet, subcutaneous injections, or intravenous infusions. So the way in which we can offer very direct, highly evidence-based treatment, all these, as you might imagine, from a big common condition, very high quality studies out there. All the drugs we have available to us fit into the territory of approximately about 50, sometimes 60% reduction in fracture risk. So really meaningful changes in fracture risk. And we can adapt the type of drugs that we propose according to the risk, according to the type of fracture site where somebody's most susceptible to, whether they've got other medical problems in the background. And what's helpful these days is, I've mentioned intravenous treatment. That's one, in fact, that you give just once a year. And mostly, if we use it, it's perhaps just for 3 years. And then we say that's enough for now, so the person doesn't need to be having a continual kind of lifetime treatment. And in fact, it's important to have very considered use of these drugs. So it's not just press the button and that's it for the rest of your life. Take this stuff. And that's quite unusual for medical treatments. It's almost a pulsed type of approach to managing bones, because we know with a lot of the treatments we have, they work over a period of time very powerfully, and they sit in the bone for a long time. So we can use the beneficial effect of them sitting within the bone by not having to keep the levels topped up. So a scenario may be that somebody has 1, 2, 3 years of treatment, and then we just monitor for 2, 3, 4, 5, 6 years, and perhaps not have to intervene in that time, other than the lifestyle and the calcium, vitamin D side of things, and then perhaps top up treatment in due course, with the emphasis being on giving bones strength, giving people confidence. I'm a huge believer in this, giving people confidence to get on with their lives, to not, over medicalize it and say, oh, wrap myself in cotton wool. I've been told that one of the things I often hear is, oh, somebody told me I've got the bones of a 90-year-old. And that's such a bad, negative, silly thing to say to people. Because if you tell somebody that, they try to adopt, being a 90-year-old, whereas actually there's so much we can do. And, you know, yeah, just be sensible, get out and get on with your life and do the things that you enjoy doing. That's why we're here, isn't it?
That's really fantastic news about the treatment. I'm very worried about over medicalising, especially over medicalising women's health. So, and there's a lot of discussion now about things like statins and things. So it's great news that there's so many different options, and they're not something you've got to take forever. Now,
No.
what about then catching the osteoporosis? Is it? I mean, you've talked about screening and things, but are there different grades of it? Does it get worse if it's
Mm.
not treated? I know there's something osteopenia and things. So
Yeah.
yeah, how do we deal with that?
Yeah, sure. You're right that um, reduction in bone density does, from a, we can get a little bit technical around this. The World Health Organization provided these diagnostic criteria for us. The main one is osteoporosis, and it relates um, one's bone density to women aged 30 to 40, so who don't have bone problems. And it's very statistical, but basically if you take women aged 30 to 40, you measure the bone density, you get an average, and then you get a spread of distribution of bone density that in those women. And then as you get older, we refer the bone density of that person back to that younger group. So you end up with this thing called a T-score. So osteoporosis is the important, shall we say, old level links to some of the studies for these drugs that I've been talking about. Osteopenia is a term that is recognized by the World Health Organization, but those of us clinically active in the field, we very rarely use the term osteopenia because it's not a diagnosis. It's a kind of a continuum. You've got somebody who's average, somebody who's a bit above average, somebody who's a bit below average, and often you get that osteopenia. So again, coming back to your point about over medicalizing, I don't like that, and I don't like the somebody comes and says I've got this bad case of osteopenia. There is no such thing as that, and that person then has got a medical diagnosis. And I say no, you don't. Your bone density is a bit. I would just tell your bone density is a bit on the low side. What can we do about your bone density being a little bit low, rather than on your health insurance form saying I've got this severe case of osteopenia, because it's not a diagnosis. And it's an awareness that perhaps we need to keep an eye on the bone density. Whereas osteoporosis is a term we have to use because it's how we've kind of built things over time, how these drugs have got authorization for their use, etc. But it comes back to what we touched upon before. When we see somebody, we talk about an overarching risk of fracture. So the bone density is a component of that overarching risk of fracture. And that's where this thing like the risk checker and FRAX comes in. GPs these days tend to use FRAX, and we can work out a fracture risk without necessarily doing a bone density in everyone. But as we do the bone density, if we have a value that is low and we do nothing about it, you can almost inevitably say that over the years to come, if we don't do anything, that bone density is going to get worse. And that inherent risk for that individual will go up because they are getting older. Age is a hugely powerful predictor of fracture risk. So a specific level of bone density in a 50-year-old is entirely different in terms of the risk of fracture if that bone density is the same in an 80-year-old. The 80-year-old's risk of fracture is much, much, much higher than the 50-year-old's because of the age and because of general health status, etc., risk of falls, etc., etc. But in terms of, we can grade osteoporosis in terms of fracture risk, and we can grade bone density in terms. We can grade it in terms of bone density as well. So we tend to blend it together to say this is the risk, these are the drug therapies we have available, which one? And often it comes down to offering a choice. It's not just doctor says take drug B. It will often be a discussion around actually B, C, and D are quite reasonable. These are the benefits, these are the risks, this is the mode of delivery. So it's about that empowerment and buying into something that, in fact, taking medication that prevents something doesn't make you feel better. It's not that I get up in the morning and I don't have my headache. It's I get up in the morning and I might have to take a tablet, but it doesn't make me feel better because it's about things not happening, i.e., if you happen to fall over, you dust yourself off and you carry on with your day rather than you end up in an A&E department with a broken wrist or something. So that prevention is you have to have buy-in. It's not appealing from a I feel better. It's I'm doing something to invest in my future so I can lead a longer, better quality, fulfilling life.
Thank you so much for making that clear. Being told, I've had 2 DEXA scans and been told that I've got osteopenia and never really understood. And I worry about it. I do a lot of sport. I do a lot of high impact. I always, when I'm jumping up and down or doing a star jump, I think I'm going to break something because my bones are fragile.
Mm,
So
mm,
thank you so
mm,
much
mm,
for
mm.
making that clear. So anyone listening with osteopenia, we shouldn't be worrying. To get checked and think about a lifestyle for sure.
Yeah,
So
yeah.
let's get back to menopause. This podcast is coming out just before World Menopause Day, so it's in World Menopause Month. Now, you talked about the decrease in estrogen, and women. I think this is probably the number one chronic health condition besides heart disease that we do worry about. So, what's your view about taking hormone replacement therapy for? It's been said as a preventative medicine for osteoporosis.
Yeah, there's, again, over the course of time that I've been involved in this, I suppose the profile and perception of estrogen, menopausal hormone replacement therapy has changed over the course of time. I think quite clearly, quite centrally, um, bones. If I'm a great believer in trying to keep things as physiological, in other words, as close to normal as possible, and of course, in women up to what's the average age of menopause 50 51, I think I'm still right in saying in the UK. If there's any issues with bones, then estrogen kind of has to be your answer unless there's something really unusual going on. And of course, in terms of our risk checker as well, if there is an early cessation of periods beyond before the age of 45, then we would absolutely be saying then estrogen has to be the way to go. It keeps things physiological, rather than thinking of drugs like bisphosphonates, etc., which are bone specific. So I think there is a very central place for estrogen in managing bone health. Absolutely. Even if we get into the setting of someone who has, let's say, osteoporosis, and they may have had fractures, particularly spinal fractures, because there is a differential effect of estrogen at different types of bone. So the type of bone we have in our spine is quite different to the type of bone we have in different in other areas, in parts of our hip and in parts of our wrist as well. And we know that women whose periods stop early, if I see a bone density scan, I can see a much greater reduction in bone density at the spine than I can at the hip. And so that is a very estrogen sensitive area. So if you're particularly focusing on spine bone density, vertebral or spinal fracture risk, then estrogen as a primary treatment for osteoporosis, particularly I would say, women in 50s through 60s, etc., it's a great treatment. Why wouldn't we be doing it? Of course, being holistic in approach and not just thinking about bones. So it is has a very central role in managing bone health and osteoporosis. As things become, shall I say, more complex, we start then to think about, given the scenario here, comes back to that kind of drug ABC that I was talking about earlier. Estrogen or estrogen replacement goes into the mix, but then we think about some of our other more pharmacological kind of drugs that are more bone specific. And then we would have the conversation with the patient. So if there was clearly, other features relating to estrogen deficiency, more systemic or bodily functions, and vasomotor symptoms, flashes, hot, sweaty, joint pain, and foggy thinking, and all the rest, absolutely, because then you're covering, you're treating the whole person. We're not compartmentalizing the bone. Sometimes and again, sometimes people, patients wish the compartmentalization of the bone because they feel that, that's powerful and directed, and because my bone density is this, I'd really prefer that. So, so I think it's about having an open, rounded conversation, and I think it's important. My background, as we've spoken about, is as an endocrinologist, so I'm very comfortable around hormones. A lot of osteoporosis services are delivered by rheumatologists who are kind of joint doctors, or doctors who kind of care of the elderly doctors, perhaps more used to seeing older people, where perhaps the perception and use of hormones is slightly different, and kind of that's the way it is. But I very much recognize that estrogen has a very central role. I think there is generally a threshold in most of us. If somebody, for instance, is um, towards their mid 70s and they have very low bone density in the previous fracture, we would probably be going for one of these other drugs, the tablets, the injections, the infusions, etc., because you're narrowing down and you're looking at your evidence base to say, I'm really after something that's going to prevent that hip fracture. So it's about choice, but estrogen is absolutely centrally important in those who clearly have early cessation of periods, early menopause, very comfortably through 50s into 60s, particularly when spinal osteoporosis is a factor. Um, so it's having that rounded approach and having discussion with people and patients.
Thank you. And I am going to dive a little bit more into that because I know so many women are worried, obviously, about osteoporosis. So let's imagine two scenarios. We've got two women,
Mm.
both went through menopause at 50, so very average. One of them has a family history of osteoporosis. One of them doesn't have a family history of osteoporosis and no risk factors. Would your advice be that both of them should be on HRT? What would you say?
So I think if in isolation, in other words, there were no other features, no kind of rebound awareness of loss of estrogen, I think I would be inclined to use a baseline DEXA as a helpful springboard, because that the individual, the hypothetical individual you mentioned with a family history, then if there is a family history that's born through that 70 to 80% bone density issue, then we would see probably low bone density. And that, I think, would be a trigger to say, well, actually, in the round, I would wish to have some exposure to estrogen for a period of time. I think that would make a lot of sense, because there is what should I say? There's the clinical outcome and preventing fractures, but there's also the psychology, which I think we've both alluded to through here. There's about feeling I've done what I can to keep myself in the best state possible with the risk factors that are active in me. So, and I wouldn't belittle the relevance of that. So I think in that person, family history, I've seen the impact of the disease. My bone density actually, it's really quite low. I'm at a point in time where I know my bone density is going to fall because I'm going through the change. I wish to go on to some estrogen in a very, informed decision-making way. I think that's very sensible, I would say. The other scenario, I think then that the bone density is going to be helpful. Because if you have good, let's say above average bone density, then do you take estrogen at that point? Medically, I think I can't really put a strong argument to support that, and it's a very personal, individualized decision around the perception of risk, I think there. But could I show you medical scientific literature to say this is the right thing to do because it's going to prevent fractures in due course? And no, I can't do that. The important thing here as well is going on to estrogen. What it does is delays the estrogen-related loss in bone density. So someone who goes on to estrogen for 5, 6, 10 years, at the end of that time, you could make a case, dependent upon bone density and fracture risk, transitioning onto another form of treatment potentially. But if that estrogen is going to be stopped, and I appreciate that not everyone stops estrogen replacement, and that's kind of, I guess, a different story. But if it is stopped, then there will be that estrogen-related bone loss, and the person will be that much older, for want of a better term. So it's not a, if I invest now, it's never going to happen. When estrogen is on the scene, it's really helpful to bone density. But if it leaves the scene, that's the time to be putting your thinking head on to, do I need something else for my bones?
Thank you. That's excellent. And so there is a narrative that all women should be on HRT to prevent osteoporosis. I'm a big fan of HRT. I think
Yes.
for certain situations, I think it's fine. But we did talk about the word over medicalizing, which I do worry about. So,
Mm.
what would your view be that, but for the people that say every woman should take HRT their whole life to prevent osteoporosis?
Yeah. So I think it's the all or none thing. So I think if we strip that back, to me, it's if women take when they are taking, or if they take estrogen, will this, at the time that they're taking it, prevent a substantial reduction in bone density and therefore reduce the likelihood of osteoporosis developing over the time they're taking it? Then absolutely yes. I think the answer to that is absolutely yes. I guess the point that probably I'm not the best person informed to address is, for how long does that estrogen continue? Is it going to be lifelong therapy? Because even with estrogen on the scene, it comes back to that point I made that, we all, hopefully, in a way, we all get older. So there will be a negative effect of aging relating to bone density. But as a principle, if there is a hormonal factor that in earlier life protects bones and you continue that for longer, will it help to protect the bones? Then yes, I think is the answer to that.
One last question about menopause, because I know it's very controversial. So, can women who take HRT still get osteoporosis?
Yes, yes, they can. So it's not a, that there are no, it comes back to the point of, no always and nevers in medicine. So absolutely. It's unusual, but there are scenarios where I will see women with osteoporosis who actually haven't gone through the menopause, and it comes back to what are the other risk factors for osteoporosis. So taking estrogen long term does not guarantee not having osteoporosis and not having fractures. It's a complex interplay. We've mentioned that bone density is a central factor, estrogen is a central factor, but there is not an all or none. It's that rounded, blended mix of risk factors. But having estrogen on the scene is clearly a helpful, positive, protective of bone density factor, most definitely. But yeah, I think that, as you're implying, I think the don't make the assumption that I'm on my estrogen and that's it. I don't have to worry about my bones again. It doesn't work that way.
Yeah, I do. I do hope that women who are taking HRT are still absolutely making their lifestyle their priority for sure.
Sure, sure, sure.
One last question about before we just almost wrap up. I've always wondered why men obviously still get osteoporosis. They haven't been exposed to the high levels of estrogen. They don't have a menopause.
Mm.
Why is there this difference between men and women? Why are men getting it less than they haven't even been exposed to estrogen? What's going on with these bones?
Yeah,
You
yeah.
might not know the
It's a
answer.
good question, and it's this is one. It's easy to answer this question with a slide. But let me see if I can kind of paint a picture. Early, because I guess we're talking about a part of life kind of over to the right, whereas really importantly, there's this kind of life course of bone health, and of course, even again, not for now, but stories around kind of in utero development and kind of maternal health and what that confers to the baby and the future person's skeleton, etc. So there's a lot of data there. But in essence, through childhood, we hopefully do things like go out and play. I don't know how much of that goes on these days. Probably not an awful lot. Probably consume dairy products. Again, not sure how much of that goes on. It's kind of Red Bull and Monster and things, I think,
God.
rather than bottles of milk. So through early part of life, and say early, it goes on for quite a while, up to about the age of perhaps 25, sometimes a little bit longer, we accrue or gain our peak bone mass. So we're built, our genetics program us that up to about, let's say, 25, boys and girls, young men, young women, will gain bone density to a point. That's our peak bone mass. It won't get any better than that. Then, up until about 40, it stabilizes. But if we look at peak bone mass between boys and girls, males and females, boys have a significantly higher peak bone mass than do girls. So the set point is higher at the age of around about 25. So then you have tracking to about the age of 40 in parallel, so males and females, and then you have a very slow age-related decline from about 40, and then through the menopause you have almost a precipitous reduction in bone density in women, not in men. So this line, and if you draw kind of a fracture line of bone density, you can see that being lower to start off with and having a precipitous reduction, then getting into age-related decline, then women touch that fracture point. Not that it's a real point, but just hypothetically, well before men, because they're over here and they're just tracking according to age. They will get there. They will get there. And of course, one of the things we've not really said here is the reason we're seeing so much more osteoporosis and fractures is people are living longer. They're living longer and, in fairness, generally being healthier. So, so men will develop fractures, will have hip fractures. In fact, some of the most severe osteoporosis I've seen has been in men, but the proportion is much, much lower for that reason. Lower peak bone mass in women and the precipitous loss around the time of the menopause. And then they both get into that parallel age related, but women get there, should we say, sooner. That's largely the essence of the differential.
So, should one of our messages be that for our young people, we need to get them exercising before the age of 25 as much as they can?
Yes, there is a really powerful message to our younger selves. Absolutely. And it's being smart enough to be able to package that message into something that is tasty and meaningful. And perhaps linked to that and around the women's health side of it, the one thing as well as an endocrinologist, um, one of the things that we get really uncomfortable about is use of Depo-Provera as a contraceptive in early life in teenage girls, because remember I was talking about peak bone mass gain. That actually, the way that that works tends to blunt that gain, so you end up with a lower peak bone mass, and it's quite a difficult conversation about something that is really convenient earlier in life, and I don't have to think about it to think, well, actually in 30, 40, 50 years time, then your risk of breaking a bone, it's a difficult story, but that as a hormonal intervention early in life is not good news for bone much later in life. Just as
Neil.
an aside.
Wow, no, that's a really, really key point. And I'm doing a lot of work in women's health, but I'm doing a lot of work in
Mm.
schools and with young people.
Hmm.
They're the future, and I worry about the way they're living their lives. We talked about. I don't think kids go out and play anymore and jump up and down, and there's lots of people who are just sitting in their rooms all the time on their Xbox or
Yeah.
whatever. And
Yeah.
we know that globally women exercise less than men. There's
Yeah.
a brilliant campaign in the UK, This Girl Can, which I've done work with for many, many years.
Mm.
So
Sure. Sure.
they're really so important to get our young people to understand why we're asking them to exercise. It's not that they should have a six pack or bulging muscles.
Yes.
It's their long term health, and I think that's going to come out in all these chronic health conditions. Some people didn't
Yeah.
like in the dementia one that we did that's out now. They didn't like the fact that we talked about preventative medicine, and they said, "Oh, but my mother still got dementia, and my father still got whatever," and they get upset. So they saying, "Oh, well, you saying I should have lived my life differently, and then I wouldn't have got it."
I
They
see.
get upset. They
Yes,
do
I
get
see.
triggered because they're past it. But I,
Yes.
I don't think two wrongs make a
Yes.
right. And I think we've got to make
No,
sure people are aware of what they could do. And it's never too late. So, you know,
totally. Yes, and I think it's seeing this kind of life course approach to disease, and more importantly to health as well. We can nudge things at different points, and the focus on kind of treating disease. Well, we're having to do that now, and I know this is a big kind of a policy issue, but the more rapidly we can move towards prevention, then it's a win-win-win scenario. And yeah, we should be having the conversation. Totally.
I totally agree. I have in my career now become so obsessed with lifestyle. I talk about it all the time, and I'm very lucky. I was someone that I've done exercise since I was about 3. I used to do ballet and things,
Mm.
and I'm a qualified
Mm.
aerobics teacher, and I do a lot.
Wow.
I do a lot of exercise, a lot of exercise.
Wow.
Some people say I
That
do
is
too
impressive.
much, but I love it. I love it, and
Yeah,
it's
yeah.
all those things going on in the background that we don't think about. So
Sure, sure.
thank you for confirming
Totally.
that. Well, I've been really encouraged by especially the treatments you've talked about and the management of osteoporosis. So, are there any new developments on the horizon that are coming up?
Well, we've had a lot of developments over the years, and in fact, we've what gosh, it's only over the last couple of years or so have a kind of a new kid on the block, that works in a different way again. So we have a huge breadth of treatments, that deal with the vast majority of scenarios that we come up against. The most recent one, as I say, that we're still kind of embedding into practice in some areas of the country, is called romosozumab, and this is a really smart drug that is designed according to how bones work on a molecular basis. And it's got really powerful, fantastic data around preventing fractures, particularly in those who are most at risk. So, so if you look about where you can make an impact, somebody who's got a particularly high risk of fracture, they may have just had a fracture, then this drug, which is actually a 12-month course of treatment, it's a monthly injection for 12 months, and then we would stop it and then move on to another type of treatment, maybe a single treatment, believe it or not, as an infusion, and that might be it for a good while to come. So that can reduce the risk of fracture, again, getting into that kind of territory of 50 to 60% wise, and actually even in studies versus the traditional medicines, is statistically more powerful than those. And actually, that's quite difficult to do. You need to be a really good drug to do that. So we've got drugs that make new bone. We've got drugs that can prevent bone from being lost. And we use that combination of what's called anabolic making bone type of drugs versus anti-resorptive preventing bone being lost. So you can move them in and out according to need. And I think, as you've touched upon earlier, what we shouldn't do is just say, "There's your drug, get on with it." Forget about it. Kind of, it's not like high blood pressure where you pretty much always need to be on something. You need to be on things for a period of time, and then you need to allow the skeleton to wake up a little bit, and then you perhaps could go on to a different type of treatment. So it's keeping it alive and dynamic, and involving people in that investment to protect, so that a longer life is a rich life, and that you're not held back by having broken something and stops you doing all those exercise things that, Joyce, you are clearly so adept at. And I think it's about, and it's a bit of a cliche, it's adding life to yours, isn't it, really?
Healthy life as well.
Absolutely.
That
Absolutely.
that's such good news that there's these new drugs. But why do they give them such stupid names? What did you say it was called? The what?
So Yeah, and of course the doctors tend to use the more silly names, whereas the drug companies put so this one is called Evenity. Again, it's but anyway, yeah, it's got to have lots of Z's, U's, and Q's and things like that in it, hasn't it? Too many consonants.
I find them totally unpronounceable, most of them.
Yeah. Yes, I think sometimes we have to practice, don't we, before going public and saying the word.
I try. I do try. Neil, that honestly, I've learned a lot, and I feel much more positive as a 62-year-old woman now about the risk of breaking something. I've only ever broken one bone, and it was a real accident that happened. But it was a long time ago now. Now at the end of my podcast. I'm very obsessed with happiness, and so I just, for a bit of fun, I ask my guests, Neil, what makes you happy, and where is your happy place?
So I'm a real traditional family man. So I suppose anything that allows me to spend quality time with my kids. Okay, it's more difficult as they grow up. I was born and brought up in rural Wales, so I'm a very outdoory kind of person. I love doing anything outdoors, whether that's being in the garden. We've got a couple of dogs, walking the dogs. I do some running, cycling, and nowhere near to the extent that you do, Joyce. But I do believe in, it's our own responsibility to do what we can to look after ourselves, and ideally outdoors. And I suppose sporting wise, not contributing these days, but I really enjoy my rugby as well. My son, he picked up a number of injuries through rugby, but for about the last, was it 20 years, we have season tickets at a rugby club near us who had financial trouble, and um, they restarted. Was it last Friday or the Friday before? So my son and I went to the rugby. So he's kind of grown up with me with rugby being very central to us, and it was just a fantastically lovely evening, kind of doing the family thing in a great environment, getting back to what we enjoy doing. So a kind of a success story. So anything being out and about and touching upon family issues, and my happy place is probably um, Pembrokeshire. My mother's family were from down in Pembrokeshire, and my head just changes into a different pace when I kind of approach the coast in Pembrokeshire.
Well, I have a small connection to Pembrokeshire. I've started doing a lot of work now with the Big Retreat Festival. I don't know if you've heard about it. It's in
Ah,
May. It's
yeah,
in
I
May.
have.
Yeah, I was there this year
Oh,
for
fantastic!
6 days, and it was
Wow.
absolutely fantastic. And it does a lot that you'd really approve of. So there's a lot of yoga, and there was lots of exercise classes, and it was very physical and a beautiful environment. So I will be along there again in
Yeah,
May.
very good,
It's
very good. We share that.
Yes, and yeah, sports with our kids. My kids all played rugby and football and tennis and swimming, and they never had 1 minute in the house. They were out all the
Yes.
time. And one of them's actually
Yeah,
doing
give them the
a,
exposure.
yeah, he's one of them's doing a soccer scholarship in the US at the moment. So they've
Wow,
got
fantastic,
they've got good
fantastic.
bones, Neil. They've got good bones.
Yes, it sounds like it. It sounds like they're putting the investment in the early part of life, which has to be good.
Yeah, they're all under 25 at the moment as well, so I'll tell them to keep going. My very, very final question, which is just a bit of fun, but what advice would you give your younger self?
Um, I think it would be to perhaps I don't know if this is a kind of a selfish one, but just just have more confidence at an earlier point in life, um, and recognize that you have a lot to contribute. I think it's taken me a long while, and my kind of route to here has been an interesting one, and a lot of steep, curvy learning. And I think if I had more confidence as to what was possible to achieve in life, but perhaps not having it has made it more of a voyage of discovery. But I didn't have expectations around delivery, so perhaps if I could have told myself, take a deep breath. There's lots that you can do here. There's lots of impact you can make, but it's taken me a long while to get to the point of realizing that.
That's really really interesting and lots to unpack there, I think. But thank you so much. We won't do that now. Well, Neil, honestly, thank you. I'm sure so many people are going to learn a lot, as I have, from your brilliant podcast. So thank you so much for giving up the time and keep up all the fantastic work. And I hope the field just becomes more and more improved and helps people with this terrible disease.
No, thanks, Joyce, and thank you for giving me the opportunity to chat to you. I've really enjoyed it.
Thank you so much.